Okay, so we have till 12:40, is it, for lunch? So we have a little bit over an hour. And what we wanted to do now, hopefully you've all been thinking about your own ideas as well as the ones you heard this morning. We'd really like to get a lot of ideas from all of you about where we might want to put our focus. And we like to do this by making sure everybody has a chance to really voice their thoughts. So we're going to break into three groups. We're going to do this physically here. And in each group, there are three questions. We're not asking you to only focus on the question that's currently on the flip chart, but if you could start with that question, then hopefully every group will at least have some input on all three questions, and we'll know at least one group spent a lot of time on the first question. So this group over here, which will be the two tables on this side of the room and the two tables on this side of the room, and Siobhan is going to be your facilitator recorder. And then the next two tables on both sides of the room, we'll look over to Simone, who's behind the thing there. And you will be focusing on, what's the question over there, Simone? I can't read it from here.
Reaching patients.
How can we reach patients that we're not reaching now?
How do we reach patients? So again, you don't need to spend all of your time on that, but at least if you start your conversation with that one, that'll be a good way of knowing that at least one group did that. And then Kathy's going to facilitate the tables in the back of the room, and there's a flip chart on the back with the question about information needs. So what we'd like to do is give you each about 30 minutes, so we have a little over an hour altogether. Then we'll bring it back, we'll get a quick report from each of your facilitators about the ideas. We'll bring them all up here. If you can record as many of those as you can on the flip charts, then hopefully we'll have a little bit of time for discussion about what are the themes between and among all of these different ideas, and are there a couple of things that really say, either in specifics or as a group of things, we really want to focus on in terms of our next steps. Okay, any questions?
Exactly, and I think this is something
So all of that needs to be some sort of common sense.
That's the refinement of it, yeah.
But you might find that their husband or wife or daughter might know support around that. So we can't just focus on the patient. I guess we've got to focus on the whole family. So I think it would work. It has somebody that is affected by this. Yeah. Just to know that he knows he may have somewhere to go.
And this idea of coffee morning room at the hospital, I like it. So can we promote that as well on a poster on the net group or on the literature? Again, the third Saturday of every month, there's coffee, and maybe the nurse attends that. Maybe it's
different organization.
So do you think it should be branded with Net Patient Foundation as well?
Like to relate you as a local template to Islam or something, something equal everywhere.
Okay, so we're going to get back together. We've got about 20 minutes or so before we break. A little bit, we can take a little more time than that to make sure we get each of the reports out and have some chance to discuss them. So maybe we'll start with the powerful statement group, since that was the first question we posed this morning. And let's see, the best way to do this might be to deal with all three questions, or take all of the question ones together. Ones all together? Yes? Okay. Right, okay. So we'll start with the powerful statement. That was Siobhan's group, and then we'll ask Simone and Kathy to come up and talk about their group's input on that issue as well. Is that the way you want to do it? You didn't get that far. Okay. Did you get the powerful statement? Okay, in that case, here's the powerful statement one. Well, you're on. We're flexible.
Okay, so you just kind of don't look at my writing. But what the theme that came out in terms of the statement, it all came back to basically to access was the need. And after a few attempts, we did come up with. I mean, we weren't going into the detail. We didn't want to, nail down the wording just yet. But I think this one sums it up. And that if a statement that would say, for example, come from INETS would be, we believe patients are entitled to clinically validated treatment and diagnostic options, and therefore, under that, because we wanted to keep it general, we discussed that actually going into, say if we did specify PRRT, for example, maybe soon that would become outdated. So we wanted something that covered everything, and the important wording in there is clinically validated, and then possibly listing the different options, according to what you're trying to achieve in your own country. We discussed the access to information, support groups, and emotional support, MDT. Those are all, highly important things. Did I cover everything, group? Any of the group want to add anything to that? Again, we were just scribbling down ideas, and it basically just kept coming back to access. And so our ideas on closing the information gap, we discussed post-appointment information being sent and being able to explain what went on in the appointment, a summary of each appointment to give to the patient. A special when people are initially diagnosed, ensuring that they've got everything they need to walk away with, in terms of the information and who to turn to afterwards, because that came up obviously in the symposium that people weren't absorbing, initial diagnosis, they weren't absorbing what was told. So ensuring that they're walking away with the correct information. And especially working with key organisations to ensure that the information is provided online. So Josh looked at INETS and to see what the patient information is provided on there, and it's actually really hard to find. It's not up the front to, in first click, you've got to click through and it doesn't actually go anywhere. So it was suggested that INCA takes this on as a project to develop key information that can be used globally, and that we ensure that it's kept up to date and it's really easy to find, and it can be, not just INETS but all the major organisations.
So this was about closing the gap of information needs for patients. We went through about 4 or 5 sheets, kind of changing our mind on how that should work. But in the end, kind of just came back to simplicity, which seemed to be the key way to try and ensure this. I think we really like the idea. I think it's a fantastic idea about this, ensuring that there's this checklist for whoever is seeing the patient. So that could be the dietitian, it could be the nurse, it could be the physician, it could be the surgeon. But whoever has seen that patient on initial contact needs to ensure that they've completed a checklist that states that support information has been given to the patient. We know that different patients require different levels of support. We know that patients require that support at different times throughout their journey. So I think there is an important message in repetition of giving out patient information. And we thought this should be standardised information, simple, really a simple signpost to support services in your country, and over-endorsed by INCA, and potentially, but maybe we thought this was too many logos, but maybe by your medical society too. But there was an important point made by Linda that too many names and logos might completely confuse the patient, and we're trying to keep it very, very simple. There was an idea of an editable PDF that each country can adapt with their own details, just print and disseminate to all clinics that see NET patients. And we do need to ensure that we don't just focus on centres of excellence and clinics that we know. We've got to reach out to all those other all those other hospitals. And I think just, backing that up, I was just saying to the group, we did an audit of hospitals in the UK, and we have 10 centres of excellence in England, but 231 hospitals came back and said that they saw net patients. So, there's a problem there, and we have to reach those people while there's a wider problem of getting patients just to be seen in net-specific centres. We talked about the checklist process must be a prerequisite for an ENET Centre of Excellence status, and the ENET Centres of Excellence or really strong multidisciplinary net clinics must set the standard. I think that's really important, that there's a gold standard that everyone can follow. Also, the idea that some of the simple information must include details of net-specific support organisations. Not all advocacy groups or charities or support groups cover all neuroendocrine tumour types. So when there's other types like MEN, or there's some specific lung net groups or FAO groups, then we must ensure that patients have access to all that information. And we also know that we probably need to target multiple clinics. There are a number of clinics that see all types of neuroendocrine tumour, but there are also clinics that only see specific types of neuroendocrine tumour patients. So that's quite important that we know where our patients are being seen. So before any of this can happen, I think country-specific, there has to be a lot of research and preparation, rather than just randomly going out and ensuring that flyers are out there. And we've talked about repetition. And in an ideal world, I think we all thought it would be great if advocacy groups could be present within net clinics, just as a source of support if anyone wanted to come over and say, well, hi, here are you, and we could, I know, Joe, you do some of that already, don't you, in the UK, but when there's multiple clinics in a country, that can be quite difficult when you haven't got staff members. We were talking about volunteers, and then there were issues with training, and so that's all a different subject area, but we were just saying in an ideal world, it'd be great if we could all be there.
So information delivery, I think. Yeah, that was standards of care. So obviously, I think when we're talking about delivery, and I think absolutely with the checklist, that's something I think even ENETS is obviously already endorsing out of our symposium yesterday, which is a great idea, and to have it standardised across there. There really has to be a real conjunction and information with medical professionals. I mean, and working with the medical professionals on what this checklist obviously look like. And we actually say here, it's really about the nurses. I mean, we can say what the patients want. The nurses can also obviously put in a lot of that information, because really, in all honesty, and we've spoken about it a lot, it's the nurses who are actually going to be delivering this information. And it might not be at the first diagnosis because it's just too much, but they might have a strategy or put in place a strategy in relation to what we come up with as well, that they deliver it across the journey and how and when they need certain support. So it's referral to a mental health after a couple of, after maybe the first meeting, and then and so on. So it would be really anything that we talk about with information delivery from a patient perspective has to really involve the nurses and their feedback as well. So what we talked about there, just with the guide, it would be maybe an INCA in conjunction with ENET pilot of information.
Two things we want to think about.
I think so, yeah. Because interestingly, we're all doing it within our own countries. We're all putting together all these information ad nauseum, but it's no point if it's not being delivered. And I think even I was blown away. I remember last year being in your symposium when you delivered the survey and said even when you and I think you even mentioned it yesterday, even when you had all the information in all the centres of excellence and did everything, what was it, 60 or 80, 60% came back saying they didn't know about you. So it's no point putting all this valuable information together if it actually won't get to them. So I think really you have to get the buy-in of those centres to actually say, do you know what, for us, this is going to work if we deliver it here or in this way or through a brochure here. Or, they know specifically how their centre might work. So I guess, that's what we were thinking about. Because I think we've got the information right of what we think the patient needs. It's just, it's not getting to them. There you go. Form a stronger relationship with net nurses, and even if they're, or upper GI nurses or whoever the nurse is in that clinic. So, yeah.
Okay, so can you flip over the chart in the middle there? Go back one. So there's really strong common themes and some things we need to work through, right? The checklist, the follow-up, the repetition theme is very strong. Between all of these, consistent information, but also that we can't overwhelm them with information. We've got to plug them into patient groups and as an important part of the process, both the medical process. Okay, great ideas, great groups. Okay, should we move on to the third question then? And that was led by Simone first, right? How do we reach out to people who are not reaching?
So I think we were looking at, obviously, how do we reach out to those that we're not even reaching now? But that doesn't mean just in the developing countries. That is actually in our own countries as well. I mean, we see a huge disconnect of, as you mentioned before, that however many hospitals are dealing with NETs, they're not just seeing in these, for us, 5 centres in Australia. They're being seen all throughout Australia. So how do we reach them? And I think, look, the probably the most achievable would be a technology strategy around, obviously, which would include social media, would include our website, especially I'm looking from an INCA perspective, making sure it's completely multilingual, we have information on there. But after we've and that would work parallel in really trying, as from an INCA perspective, hitting the societies and hitting the healthcare professionals. I know, and if I could probably do a poll of who started up an organisation being asked by the healthcare professional to do so. Did anyone put up their hands if they were asked to set up a group because of the healthcare professional doing it? I mean, you're the healthcare professional. Grace, did you set up the group? Oh, you came into the group. Did a healthcare professional person encourage you to start the group or to get into the group?
It was already.
Sure. Well, okay. Well, I actually do think that a lot of the healthcare professionals sometimes in the developed country are really trying to, say, this is what's needed. Exactly. So, Uganda hasn't actually got a patient to do it yet. So I think targeting, if we're trying to improve our reach, and so that's medical oncology groups in South America, gastrointestinal groups. This is how we started it, at a small level when we first launched the foundation in Australia, was really hitting all the conferences, going to the gastrointestinal conference, going to the oncology group conferences. So maybe in these areas we really need to hit not just, we're probably speaking to the converted when we talk ENETs or ComNets or NANETs. We need to be going to all those other oncology, ASCO, ESMO, whatever, to be telling them who we are and what we're doing as well. And that's not just oncology groups, but also nurse-specific groups within those countries as well. And that's including our own. So from that, working parallel, before we even do that, we really need to get this up to speed and make sure our website is pretty professional and developed. And we could look to do, getting grants around that. There's a lot of, philanthropic companies that want to help with technology and reach of global and especially in developing countries. So that's something that INCA could actually do there as well. Obviously, when we're looking at multilingual, we're looking at health literacy and, possibly, the cartoons that have been working across each country, looking more at that sort of side. Contacting other rare cancers. So I think if we can get this really up to speed and who we are and what we do and how we can help before actually going here to those areas that we need to develop and grow some groups as well. But we need to get this pretty professional first.
we did this one in a bit of a hurry at the end. So we, just to summarise, there was ideas in terms of seeing if centres of excellence, it becomes compulsory to advise of a patient group in the area. Adding to their checklist, to advise, which I think others have talked about. Utilising registries, so we know not every country has a registry, but if there are, seeing if we can work together in terms of if they are collecting information, asking the question within that, when they're collecting the information, asking if they would like to be advised of a patient group in their area. Because obviously we can't, for privacy laws, you can't necessarily tap into the registry, but there must be ways around it. So it's just basically finding ways to utilise what's already been collected. And the same along, whatever databases are around the place, seeing if we can tap into those. Partnering with other larger organisations, so, maybe nurses networks, or in our country it's called the Cancer Society, and working with them to help us, spread the word, going through GPs, but again, reaching GPs is really difficult, but also providing webinars by INCA so that they can be used in any country, just being able to reach people that may not be near a centre of excellence.
There just has to be, we have to really, really remember that all of the information that we've got from our surveys and from all the information about the unmet needs are from engaged patients. So it's really, really biased. We don't know what the unmet needs are of the patients that we don't know. So I think we have to be really careful to keep that in our minds. These are patients that want to be involved, that are engaged. So we actually don't know the answers to the unmet needs, really. And that's our problem. No, we didn't really get very far. I don't think we have a huge more to add, except a little bit about the realism, or again, the reality of REACH. We also have to accept that there are a number of patients who are not interested at all in contact or advocacy groups or sharing their stories or buddy systems. That's not their thing. So let's not try and aim for 100%, because that's just never going to happen, and we shouldn't expect that. We kind of went more we were looking at from governmental level, from legislations, and I think we were thinking of this as a more top-down thing, focusing on cancer strategies, but then when we were asking about the different countries and whether they had cancer strategies, there was, well, they're not very good, there's an odd policy, and whether that's something that we need to really be ensuring that every country has a good cancer strategy that includes information and guidelines for rarer and uncommon cancers. That our UK or our English cancer strategy is new, and we've just put out a report because out of 96 recommendations in that strategy, there's only 2 that mention uncommon cancers, which is completely rubbish. So I think we were looking at whether we need to really start from the top and get governments to ensure that in their cancer strategies or whatever they have equivalent, all patients get fed into specialist units, because then obviously we can improve those numbers. And there was just a nice quote that somebody said about, it's not enough to just enough. It's just not good enough, so don't give it a go. We need to ensure that clinicians and doctors aren't just giving it a go in treating patients because they think they know what they're doing, because the likelihood is they don't. But that's really as far as we got. I think everyone's done much more on that.
Well, great. Great energy, great morning. Certainly some common themes. It also strikes me in this last one that whether it's the website, the outreach to the medical societies in places where there aren't patient groups, that that third pillar of ours, supporting and reaching more patient groups around the world, those are the kinds of things. It also suggests we may need to make investments in things like our website that have implications, obviously, for our budget and where we might go to for some help with that, not just in terms of the content, working with the medical societies, but also with the cost of really upgrading that significantly, being able to register whatever we're going to call it, patients. A lot of great ideas. Any final thoughts? I'm sensing a little bit of it's lunchtime exhaustion, and it's been a busy morning, but a couple of last comments? Yeah.
I think it's just about once the SEER database stuff once your version of the SEER database gets done over, it won't be considered rare anymore. And how does that impact how we're going to deal with things? You already have that problem in Australia because you're on prevalence, not on incidence, if I remember, or something. Well, they're all on prevalence, but it's a lot lower or a lot higher, whichever. You already have that issue, but we're getting close. In the U.S., it's 200,000. And you're no longer considered a rare disease, and we're going to be at this last thing 175,000. So that will impact even who we get to deal with and how we approve drugs. So just think about part of that as you start adding these strategies forward. I mean, the drug companies will do it by slicing this up even farther, or we'll start splitting again and not be a unique set of diseases. So that's going to present another challenge that you're aware of. That's all. Here you go.
What do people have in terms of their classification of disease? Because we have rare, uncommon, and common. And we've just moved out of rare and gone into uncommon. But is that word uncommon used throughout different countries?
Sounds like in the Commonwealth.
No. Or is it just common and rare?
Well, and there's a significance to rare, especially with respect to orphan drug status and everything else, so it's important. Certainly in the U.S. we're watching that very carefully. So the other thing about the SEER database is, if I understood some of what was presented, which I missed the presentation, there may be some new data about very important things about how people are getting treated, how long they're living, et cetera. That'll be some very powerful messages for our communities coming out soon, too. So stay tuned for that when that gets published, we hope soon, right?
It's in print.
Okay.
Journal of Clinical Oncology. Yeah.
Very positive news. So maybe we'll talk a little bit about that over and after lunch. We have lunch now. It's 12:50. We're going to reconvene at 2 o'clock, correct? So enjoy your lunch, and thank you. It was a great morning. And thank you again to the group leaders and everybody for all your energy and support. And please, over lunch in particular, we have our sponsors with